Monday, everybody. I am really delighted to welcome you to the SIREN and Camden Coalition webinar on the Accountable Health Communities Model Final Evaluation. As most of you probably already know, the AHC, Accountable Health Communities, is a large, very rigorously conducted federal evaluation of social needs navigation in the US. In February, CMS released the final evaluation report, which covered the full model period from 2018 through 2023. The results are striking and obviously highly relevant to the work that all of our listeners are doing on social care integration, whether as researchers or practitioners or policymakers or other leaders in the healthcare system. Our plan today is to briefly review the report findings and then spend most of our time hearing from leaders from 3 model sites. And I'll introduce our panelists in just a moment. I've asked them to talk about their unique implementation experiences, their perceptions of model impacts at their sites, and the sustainability of model elements in each of their different locations. I'm really looking forward to hearing from them today. But first, I am obligated to share a little bit about SIREN. So for those of you who are not yet familiar with our work, SIREN is a research and dissemination center at the University of California, San Francisco. Our mission is to conduct research, support other researchers, and synthesize and share research on social and medical care integration, and then put it into the hands of people who can use it, like all of you. So here we are. One of SIREN's most used resources is our Evidence and Resources Library, which includes over 4,500 resources on social care. It's updated several times a month with recent publications. Library is super easy to search. Use is completely free of charge, so please check it out if you are not already familiar with it. You can also stay up to date with SIREN's free monthly newsletter. So the newsletter includes a list of the social care research published and added to our library each month, or a curated list of that. And it also has other information about social care news and events. You can sign up to receive our newsletter using the QR code or just going to our website. And finally, while I've got your attention, I want to give a quick plug for the Fall Conference Putting Care at the Center 2026. Which is being convened by our partners here at the Camden Coalition and the National Center on Complex Health and Social Needs. And this year's co-sponsored by Kaiser Permanente. So SIREN will be there. We're a content partner for the data and evaluation track. And of course, we would love to see lots of you there. A little bit of logistics. The webinar is being recorded. I feel like we always get that question. A link to the presentation will be sent to everybody who registered and posted on our website when it's available. So feel free to point other people in that direction. We welcome your questions and comments, but please use the Q&A function to ask your questions. And we'll try to get to as many of them as possible at the end. And with that, I am just so lucky to be joined today by 4 inspiring people. And I'm going to introduce them, and then I'll do the brief overview, and then we'll turn it over to them. Catherine Jantz is the founder and principal of Hearthwise Consulting. Catherine served as the director of the Accountable Health Communities model at Rocky Mountain Health Plans, leading the plan's AHC program implementation across 21 Colorado counties. Marisol Caban is an Associate Director of Community Engagement and Capacity Building at the Camden Coalition. Marisol oversees the Camden Core Model and Medicaid redetermination programs, excuse me. Erin Truchel, also from Camden, is their Senior Director of Data and Analytics and will join Marisol in the discussion section of the webinar. And finally, David Kendrick is a physician informaticist and chair of the Medical School's Department of Medical Informatics at the University of Oklahoma. David founded the My Health Access Network, Oklahoma's state-designated health data utility, which he will tell us about. It serves as a community-governed platform connecting health data for more than 4 million patients across the state. And David led My Health Access Network's participation in the AHC model. So we clearly have a very expert group today, and I'm really excited to hear from you. So let's get this party started with a brief overview of the AHC model evaluation findings. You should digest everything that I'm going to say alongside the actual reports, all of which are available on our website. And then I also want to point you towards this terrific 2025 webinar that we did with other Siren friends and family, Caroline Fichtenberg, Danielle Hessler, and model developer Don Alley. That webinar focused on the third evaluation report. And again, you can find all of those on the website if you're interested in diving deeper. So, brief overview. What was the AHC model? Model was launched actually in 2017 by the CMS Innovation Center. At its core, CMS was asking a simple and important question: will systematically identifying Medicaid and Medicare patients with unmet social needs and connecting them to community resources reduce healthcare costs and utilization? So awards were originally made to 32 bridge organizations across the US that were committed to partnering across clinical and community organizations. So together, the partnership screened more than 1.1 million beneficiaries for 5 specific drivers of health. The model referred to these as core needs, and site could have added other needs to their list, but they included the ones that are on this list: housing instability, food insecurity, transportation problems, utility insecurity, and interpersonal violence. 4 sites ended up dropping out of the model. The final report reflects findings from 28 organizations. 87% of the population served ultimately by the model were Medicaid only or dually eligible. So the program really reached a high need, high cost population that was anticipated to benefit most from this kind of intervention. The model came in 2 flavors: the assistance track and the alignment track. Sites in the assistance track were part of an RCT. In those sites, beneficiaries who screened positive for at least one core need and reported 2 or more ED visits and were community dwelling were randomly assigned to get a referral list about community resources and one-on-one navigation services, whether by phone or in person, for up to 12 months. The control group received the same referral list, but no longitudinal navigation services. So sites in the alignment track participated in a community quality improvement model. So all of their eligible beneficiaries received navigation, but the award organizations and their partners were also asked to engage in system level work to align community resource capacity and local needs. And 2 of our presenters this morning, oh my gosh, are from alignment sites and 1 from an assistance site. In total, 37% of the people who were screened for social needs had at least 1 core need, and 18% met the other eligibility threshold for navigation services. So the final quantitative results are from 18%. It actually, some of them dropped out, so it ends up being about 13% of the total number that were screened. The headline finding is, across both tracks and both payers, Medicaid and fee-for-service Medicare, the AHC model generated more than $200 million in net savings over the model period. So no joke, that's net. It was meaning that it's after accounting for program operating costs. And both tracks showed savings, both assistance and alignment. 80% of the savings came from Medicaid-only beneficiaries, who made up about 70% of the enrolled population. I'm going to share some details about those healthcare utilization changes that explain the savings on subsequent slides. So you'll see a little bit more about how they came to those savings numbers. They really weren't just a cost accounting artifact. They were driven by real reductions in healthcare utilization, which might be interpreted as improvements in care quality and appropriateness, depending on how you look at it. Among Medicaid beneficiaries in the assistance track, the intervention group had lower total expenditures than controls, and that came from fewer inpatient admissions, fewer unplanned readmissions. For the fee-for-service Medicare beneficiaries in the assistance track, they also saw lower total expenditures, and it generally came from fewer avoidable ED visits and fewer unplanned readmissions. The findings in the alignment track were very similar. An important caveat: the direction and magnitude of those estimates were consistent with the assistance findings, but some of them were not statistically significant, although the total lower expenditures was significant. The evaluation team said that this was likely a statistical power issue, so the sample size in this design was just too small to detect effects. So it wasn't a true null effect. It was most likely consistent with the assistant's findings. So not all beneficiaries benefited equally. The subgroup analyses are especially informative. People who benefited most were Medicaid beneficiaries with more than one social need, people with behavioral health or chronic physical health conditions, and then in the Medicare population, people with transportation insecurity. And the way the authors make sense of this is that Medicare does not cover non-emergency medical transportation, unlike Medicaid in many states, and transportation was the only need in the Medicare population that was itself predictive of higher Medicare expenditures. So Medicare patients with transportation barriers might have had a harder time accessing preventive care, and they ended up relying more on acute and expensive care. So providing transportation or helping them access transportation ended up reducing their acute and expensive care. I just want to take a moment more to talk about the mechanisms, and then we'll turn this over. The original theory of change behind the program was super straightforward. Navigation leads to social needs resolution, leads to better health, leads to lower costs. But the survey data collected about 6 months post-screening showed that the beneficiaries randomized to the intervention group did not have significantly higher rates of social needs resolution than the control group. The costs came down anyway. So why did that happen? And the evaluation team described 4 plausible mechanisms, all of which were consistent with what we've seen in other literature and what we've written about at SIREN. First, plausible mechanism was trust building. So the navigators developed trusted relationships with their clients, which might have increased patients' engagement with the healthcare system more broadly, making routine care more effective. Second, navigators also provided some really basic healthcare coordination, so helping clients remember appointments for chronic conditions or to access primary care services. So this is essentially care management, but delivered through what was essentially designed as a social navigation channel. Third, some populations, like those with chronic conditions and behavioral health needs, were more likely to achieve social needs resolution. So it may have been that for those people, it did work through a social needs resolution pathway. Those are the same groups that had the largest cost reductions. But the aggregate effects on health might have been driven by the concentrated impacts in those high needs subgroups that the social needs navigation did work. And then finally, even partial needs resolution, say, like, as I mentioned, the one-time transportation to a medical appointment might have been sufficient to improve the downstream health utilization effects, but not enough to cause a change in the social need, the underlying social need. So anybody who's interested in the mechanisms might also see our team's Milbank quarterly paper on the logic model that we're positing behind social needs investments in the healthcare system. So that about wraps it up. You should have gotten the message that this was a robust, large-scale demonstration showing that the accountable health communities achieved cost savings for both Medicaid and fee-for-service Medicare patients mostly by improving healthcare utilization patterns that involved lower ED and inpatient utilization. The final chapter of the 4th report distills several lessons from the 5-year program. Large-scale screening is feasible, but you have to repeat it. I think 50% of the patients had a change in their needs by 6 months, so doing it once a year may miss many needs. Navigation services really matter, whatever the navigators were doing, and it was a big black box. It worked better than handing people a list of community resources. Transportation seems to be a uniquely high impact need, particularly for Medicare patients. And then finally, outcomes were largely driven by people with specific chronic illnesses. That's where the return on investment was the highest. Okay, so now back to our panel. This is the amazing group that we get to hear from now. Every time I talk to somebody from one of the model sites, I am blown away by how much work it was to get these programs off the ground and running smoothly. And we get to hear from those people about how they made the magic happen. Not only that, but how they're keeping it going in their respective sites. Not all sites have been able to keep the programs singing. And so the people that we've assembled have some particularly unique insights. Catherine, I'm going to turn it over to you. I'm going to stop sharing and I'm going to let you share your screen. And I'm just so grateful to the four of you for joining us today.
All right, can you see my screen?
Yes, ma'am.
All righty. I'm Catherine Dance. I was the program director for the Cannibal Health Communities model in Western Colorado, which was run by Rocky Mount Health Plans, which leads me into my disclaimer, which is that I'm not an employee of Rocky Mount Health Plans, and the views in this presentation are mine and mine alone and do not reflect the official position or policy of United Healthcare or any of its partners, affiliates, or subsidiaries. So our model was in Western Colorado, which is a very large geographic area. It's about 40,000 square miles with one small city. So in that purple region, there's a city called Grand Junction of about 60,000 people. In order for us to have any hope of achieving the screening numbers desired by the Accountable Health Communities model, we had to engage 72 brick and mortar clinical sites, representing 55 organizations. We trained over 500 screeners, including front desk staff, medical assistants, nursing staff, care coordinators, community health workers, and the occasional physician. And we completed over 100,000 screenings. This is a much lower number than you're going to hear from some of our other panelists and from some of the other models in the report, but a number that we're incredibly proud of. In one town in southwestern Colorado, this represented 50% of the population. So it was a significant lift. We had a couple of other things that were different about our model. We added a social isolation question, and we were an alignment site. So because our model was rural and frontier, unlike in an urban setting, we couldn't hire a dedicated team that would be focused on AHC and could become experts in AHC. We really had to mobilize the existing infrastructure and the existing staff. So we built the screening on the local health information exchange. We primarily used existing staff who are based in community to do navigation. For the alignment functions, we divided the region into 5 subregions, and each region we partnered with a trusted local convener like a health alliance or public health entity. This meant that our AHC model was a lot of people. And so we really had to think differently about our approach to training and onboarding. Sort of early on, we thought we could do these very succinct trainings, heavily focused on knowledge and skills. Here's the model, here's the screening, here's how you do it, here's how you enter the data. But over time, we found that we needed to invest a lot more time on the why. The attitudes and the beliefs of the staff who were doing the screening and navigation both impacted whether or not they prioritized this activity over the many other activities on their desk. And it also impacted whether or not they were effective. We similarly found that we needed to think about how to do quality improvement that really connected each person with the mission and with their own impact. So we started providing staff level reports. So each screener would get a report saying how many people they personally had screened that week, associated with clinic level impacts. So how many people were identified with needs, how many people were connected with navigation, so that on a weekly basis, we continued to feed them with information that connected to them to that bigger vision. We experimented with a lot of different incentive models. So early on, we had an incentive structure where we incentivized clinics because we didn't pay for screening. And so we were trying to figure out how we could financially incentivize people. And the clinic incentives were largely not that helpful. They weren't large enough to change clinic behavior. So instead, we trialed a number of different programs where we incentivized staff directly, obviously with the permission of their employing organization. And we found that incentivizing the staff who were doing the screening was extremely impactful. Largely, those are front desk staff members or medical assistants. And we learned from later work that we did that many of them were experiencing social needs themselves. About 20% of them reported food insecurity amongst our screening population. And so those incentives were really powerful. Similarly, for our alignment function, we provided monthly data about community level needs and resources. And that data, I think, was one of the biggest impacts we had. Being able to feed our communities in Western Colorado data about their community really changed the community narrative about the needs in their community, as well as the gaps in resources. So just a few examples of insights we had added this loneliness question, and we found that loneliness was highest in 19 to 21-year-olds. For any of you who've done loneliness research, I think this is a fairly common finding. But for us in Western Colorado, especially during the pandemic, it was quite surprising. All of the efforts around loneliness had been previously quite focused on seniors. And so having this data at the community level really changed some community conversations, especially in our ski resort areas and other areas where there were large numbers of 19 to 21-year-olds who were feeling disconnected and who were feeling lonely. We also found high rates of interpersonal violence in men. And I just have to make a note, we used the HC guide around data, so we only had a binary gender. And so this does hide people who have other gender identities. But for people who identified as men, we saw interpersonal violence that was happening outside the home, in workplaces, in community settings. So people who are homeless, who are experiencing in homeless shelters, who are experiencing interpersonal violence with adult parents who did not live in the home. And we found that was really a gap. We ended up having a number of conversations with community health centers, and many of our clinics started screening for interpersonal violence for men and women when previously they'd only screened in women. We also were consistently surprised by the rates of social need in higher income populations. So about 10% of households earning 35 to 50,000 reported a housing need, and about 5% of people with over 75,000 in household incomes were reporting a housing need. And so again, that just normalized, destigmatized social needs and really identified some key gaps in community resources. So one of the findings that we thought was really interesting is that for us, screening alone reduced inpatient stays. So as you can see here, it reduced inpatient stays about 20%. Like the national evaluation, navigation had a much bigger drop in inpatient stays. In our data, a successful navigation contact, so not just opting in, but actually talking to our navigators, resulted in a 52% drop in navigation. We were pretty surprised by this finding because, like the national finding, we did not see a high rate of need resolution. And we know from any number of national peer-reviewed literature that just providing screening or resource referral is unlikely to connect people to resources. But we have a lot of hypotheses around how that made people feel known, how it made them feel more connected to their care team, and maybe help their care team to create care plans that worked for them. For us, one other thing that I think was slightly different than the national findings is we felt like there was a sweet spot in navigation for people who had very complex needs, significant behavioral health needs, significant substance use needs, were actively homeless. Our AHC navigation model was not very successful at supporting them. They needed more intensive on the ground navigation than what we were able to provide through the AHC model. We were more successful with people who were earlier in their acuity for social needs. So people who needed, help with a rent payment versus finding a place. Because our model really was about mobilizing the existing infrastructure and the existing system, I think our sustainability was sort of baked into the cake. We changed the culture. We changed the conversations that we're having in communities. I cannot tell you how many clinic staff told me I was so surprised that I was so surprised that my patient was experiencing food insecurity, or my neighbor was worried about losing his home. It just totally changed the conversation in Western Colorado about the prevalence of social needs and the needs of the community. And that culture change, sustains without any additional model investments. Similarly, because we relied heavily on local organizations and existing staff, those staff continue to lead those efforts. Clinics continue to have in-house food programs. All of our alignment community lead organizations continue to provide leadership in their communities around health and social care. And the leadership that brought Rocky Mountain Health Plans to the AHC model also continued. Rocky Mountain Health Plans continues to invest in community-based organizations and community-based care teams, has expanded its investment in community health workers and doulas, in part because of the findings from this model, and now reimburses for social needs screening and risks adjusts for social factors for primary care and behavioral health. So with that, I will pass the baton.
Thanks so much, Catherine, for that presentation. I think we're going to Marisol. So Marisol, if you can share your screen.
Am I sharing my screen now?
Yes, we can see it.
Okay, thank you for that. Okay, so hi everyone, and thank you for joining us today. I'm glad to be here with Siren Community to share a journey we have been on for several years. From accountable health communities model to regional health hubs, we are now building in New Jersey. Over the next few minutes, I want to walk you through three things: the lessons we learned about implementation, what the data actually showed us, and how those HC experiences shape the regional health hub model we are implementing today. So a little bit different from Catherine, and hopefully much of this information isn't duplicated. Before I get into the lessons learned, let me ground everyone into who we are. The Camden Coalition is a multidisciplinary community-based nonprofit. Our work started right here in the city of Camden, focused on people with complex health and social needs. Over time, it has expanded across New Jersey, and when we share the learnings that nationally. On a national level. In New Jersey, we are designated as a regional health hub. The role was established through the state legislation, and it helped shape much of what I will describe today. As a regional health hub, we convene stakeholders around state Medicaid priorities. We operate a health information exchange that connects data across providers and partners. We serve Medicaid and other state departments as a local expert and strategic planning partner. We run pilots and demonstrations to test innovations, and we carry out quality improvement using population level data. That combination, community roots, a statewide convening role, and data infrastructure is what allows us to translate AHC experiences into a sustainable model. So with that grounding, let's start with what we learned about implementation. Sorry about that. One of the earliest lessons from AHC was that our approach simply could not be cookie cutter. Every site needs its own strategy or needed its own strategy, tailored to its staff and its patient population. The first big shift was engaging frontline staff early, not relying solely on leadership. When we spoke with people actually doing the screenings, they understood the patient's dynamics. They could tell us what would work and what wouldn't work, and they adapted the workflows to fit real clinical conditions. The second was tailored to site protocols. We customized screening frequency, timing, staffing models, and even the scripts we used to engage patients. We identified on-site champions at every location. For us, this was a collective effort with 4 health systems, 2 FQHs, and other partner organizations. Every community is different resources, different relationships, different levels of readiness. That is one of the biggest things AHC taught us. And when we built the RHH model, we made sure each region could adapt to its own reality while still working forward the same statewide goal. We also had to get a little creative with how we motivated staff, which brings us to our next slide. This one was a fun one. To boost engagement, we created a March Madness style bracket system across competing across other sites. Sites went head to head based on screening numbers in a bracket style elimination of rounds. The punchline here is there were no prizes. Bragging rights alone drove significant increase in rates. People are competitive. We saw that, we learned that, even when the only thing was recognition. That was just one of many things we did to help boost screening numbers. It reinforced a core idea that carries straight to our RHH work. A standardized approach to identifying needs works best when paired with local engagement strategies. The RHH model builds on this by formalizing cross-sector collaboration while leaving room for communities to adapt. So those were our implementation lessons. And let's talk about what actually we observed in terms of impact. Here's what the data showed us. Across the work, we completed over 33,000 SDH screenings, navigated over 7,000 beneficiaries, and operated over 40 screening sites. A key findings stand out. First, screening alone isn't enough. Communities need an infrastructure to coordinate responses across organizational systems. A checklist by itself does not change outcome. Second, AHC validated something we have experienced on the ground for years. Healthcare systems alone cannot address the needs driving poor outcomes and high utilization. And third, the early RTI national evaluation showed our intervention group significantly lowered ED visit rates for Medicare fee-for-service beneficiaries. That alone is a real measurable impact. The major takeaways from AHC was that sustainable impact requires regional coordination capacity, not just siloed interventions. These numbers prove that the concept, the RHH, is how we operationalize it. Before I talk about the regional health hub model itself, let me put together the key lessons AHC gave us because they are what the RHH model is built on. Healthcare systems cannot do it alone. The factors driving outcomes happen outside of healthcare. We need real partnerships with community-based organizations, social service agencies, and public health. Screening alone is not enough. Identifying needs matter, but without infrastructure connecting people to services, screening does not change outcomes. Sustainable impact requires coordination. Isolated programs have limits. Real change requires coordination across organizations, sectors, and systems. Trusted community relationships matter. CBOs are often best positioned to support Medicaid members, but they need stronger infrastructure and support to fully participate. Fragmented data limits impact. Without shared information, it's hard to know whether needs are being addressed or where the gaps are. And finally, communities are not the same. Effective models need balance, consistency with flexibility, and local implementation. Ultimately, AHC made the case that addressing health-related social needs requires more than individual programs. It requires coordinated community infrastructure. So this is where the regional health hub model comes in. The RHH isn't another program, it's the infrastructure to coordinate at a regional scale. A few things the model adds. First, infrastructure as intervention. The hubs are the connective tissues linking healthcare, public health, Medicaid, CBOs, and statewide agencies. Second, governance and implementation capacity. Partnerships need stewardship, and hubs provide dedicated governance to keep stakeholders aligned and efforts moving. Third, HIE-enabled regional data coordination. Regional data sharing improves visibility, coordination, accountability, and accountability across organizations. Fourth is the flexibility with statewide alignment. Hubs tailor to local needs while still advancing statewide goals. And finally, support for Medicaid transformation. Policy alone isn't enough. Regions need ongoing technical assistance, coordination, capacity to actually operationalize change. Bottom line, the regional health hub model moves us from individual programs to ecosystems coordination, scaling the AHC lessons through sustainable infrastructure. The journey from AHC to regional health hubs really represents a fundamental evolution from proving the social determinants matter to building infrastructure actually addresses them at scale. There's a lot that went into this, a lot that I couldn't share. They didn't have, we had limited time, but I thank you so much for your time today. Our contact information is on the screen and we would love to continue this conversation. Thank you all. Stop sharing.
Thank you so much, Marisol. David, you're on.
Great.
We can see
Can you hear me okay?
Yep.
All right, great. Okay, so the Accountable Health Communities model in Oklahoma took the form of something we called the Route 66 Consortium, and that was largely for political reasons because both the Tulsa end of the turnpike and the Oklahoma City end of the turnpike wanted to do the program, and this was the thing they had in common. That was Route 66. So that's how that name came to be, and that was just the first of many, let's say, community and political compromises that went into getting this project done. So My Health is the health information exchange in Oklahoma. It's now, I'm happy to say, the state designated entity as well for health information exchange. And it's not lost on me that all three presenters today had strong health information exchange engagement in building their efforts. I think that's important to acknowledge. This is My Health as of now. As of that time, it was a bit smaller, but it's over 15 years in operations, 130,000 clinical encounters a day. and receives real-time ADT information for more than 90% of clinical encounters in health systems. You all know this, the bridge organization responsibilities. This is what the model looked like, and I especially want to give a shout out to Jennifer Ferris, who's on this call, I see, who ran this program for My Health, and really she and her team accomplished what I'm about to show you. So welcome her to comment as well as we go through. And this is what it amounted to close to the end of the program. And you can see that we had navigators. Our navigators were in our city county health departments, which was a very smart move that I can't take credit for, but that's what was achieved. And I'll start with the operational challenge, because I think we're a bit different operationally from many of the programs. If the goal is 100% of beneficiaries would be screened upon registration, we did an initial time and motion study once we were told you're going to use the AHC screener. And our study showed 12 to 15 minutes per patient to do the screening. And if there was a need detected, up to 20 minutes to get the tailored referrals in the patient's hands. That's not even getting a closed loop or any of those things. And so, obviously, the health systems, practices, and emergency rooms that had initially committed to participate dropped to zero once it became clear what the workflow was going to be. And we had to come up with a different approach. This term, non-medical drivers of health, is sort of a euphemism we use in the South, especially Oklahoma and Texas, to describe social determinants of health. And we observed that this is the way the data looked. I mean, funders had a little bit of data, and it was a mile wide but only an inch deep. But across the community, as clients needed services, if they needed one service, they likely needed others. And our observation, as we'll talk about in a moment, was that these services evolved over time as people needed additional programs. So this is what we developed. And I can tell you, I made 2 different trips to meet with the team at CMMI about this to get permission to make changes. We made a run at lowering the reading level. We made a run at doing smart questions, so only the necessary questions were presented. And basically everything we attempted until this point was not going to be satisfactory to them from model design. And so I said, do you care how we deliver the screening? And they said, no, not really. So that's how we pivoted to delivering the screening in a mobile form. And what you see here is generally our workflow, which is upon encounter registration, the patient checks in, and as a health information exchange, we receive that data in close to real time, about a minute, to know that a patient is sitting in a waiting room at this moment seeking care. And that enabled us to take the next step, which was to use that information to deliver a mobile screening directly to that patient's device that most of the time was tied to the number that they had just registered with, overwhelmingly actually. And then when they completed their screening, we processed the results, and we had a resource directory, community resource directory, that we matched to the patient's needs and their home location, and delivered to them a tailored referral to 3 services per reported need. And then finally, those who had more than one emergency room visit in a year were forwarded on to the navigation program. And we'll talk some about that in a moment. And we did that, as I mentioned, through the city county health departments with a team of community health workers. So our mobile screening was pretty simple, looked like this. Ultimately, I think it took only 3 to 4 minutes for a patient to complete this at the point of care. And then we would dive into our community resource directory, which had, services in all 77 counties of Oklahoma to pull from. And we would match the patient's needs with the place they lived, their geography, and the services close by. And then the patients would get a tailored referral to their needs that included a lot of information, things on eligibility, information on eligibility. And one of the nice things was, because this was not delivered on paper and because it came to their mobile device, they could just tap on the phone number and be speaking to the agency. They could just tap on the link and go into an enrollment form, for example. So for, one thing in particular that Jennifer and her team were able to pull together was referrals or needs in the food area. One of the services offered was a link to the SNAP application for Oklahoma, and that was a partnership with the state to do that. Governance was critical for this work, keeping the community engaged in the social services part, as well as the clinical world engaged in our governance. And I show you this. This is only part of the way through the model, but what I wanted you to take from this is that we started pretty small in August and then had sort of a meteoric rise in the volume. And this wasn't just signing up additional clinics, it was also the volume of responses coming from clinics over time. Really important to have a scalable process. This shows how we were struggling there in the orange line. In early days in 18 and 19, and the community average or the AHC average across all the programs was this red line. But you can see there where we began to exceed and then never really looked back through the rest of the program in terms of the amount of volume of screenings and referrals that were getting done. I would also say that this stops really kind of at the beginning of the pandemic. You can see that drop right there as ERs were closing. And I couldn't find the follow-on to this, but basically the model was our model implementation was unperturbed by the pandemic. Largely, the numbers just continued to rise because even as people shifted to telemedicine, they had their phones. So here were the results through almost the end of the model, which showed over 4.6 million offers to screen, almost 1 million responses, over 300,000 patients with needs, 400,000 of individual needs reported. We're able to deliver the screenings overall. This is, even to the elderly, even to, phone numbers changing or people who reported home numbers. We were able to overall deliver it 83% of the time, had an overall 21% response rate. And you can see the breakdown was food, housing, utilities, transportation, and interpersonal violence. Average of 1.7 needs per person who reported a positive screening. And 85% of the housing needs were not, I need housing, they were my living conditions are horrible, which pointed us at a completely different set of services. This is the screening, the results by clinic site type. So no surprise here in general. Emergency rooms had a higher incidence of needs reported than primary care clinics. Interestingly, our specialty clinics were somewhat high. That's largely because we had high risk OB among those specialty clinics. And then if we look at need types, again, the overall need rate here, and then food, housing, utility, transportation, and safety. And then this is by insurance type. Now, one thing about our model that may differ from others, and one of the reasons our numbers were so high, is we went ahead and screened for the uninsured and the commercially insured as well. We paid for that out of our own cash reserves at My Health, didn't use federal money for that, but that enabled us to have a full 360-degree view of the community and the population. And so you can see on this slide, the uninsured obviously had the highest need rate, and then Medicaid, and then Medicare, and then commercial. But if you look at the overall need rate, even the commercial population reported a 17% need rate. So I think that is similar to what they found in Colorado, and certainly we can endorse that our commercial insurers their eyes were opened by this need to get some screenings for their populations as well. And of course, the same order of significance in this. These are the preliminary outcomes that the CMS evaluation team put out as we were sort of midway through the model, all encouraging signs. And most of these proved to be true in the final results that we've already reviewed. But I wanted to show you an additional outcome that I was asked to put together, in large part because ONC approached me to say, have you been able to do anything or provide any evidence of actually reducing provider volume? You may be aware, but that was an important part of the 21st Century Cures Act, was to reduce provider burden. And precious few things, maybe aside from AI scribes now, have actually been demonstrated to reduce the burden on providers. So I was able to pull together this model, which showed a total of 250,000 hours of provider time saved by doing this mobile screening approach and referral approach. And based on pretty low hourly rates for cost, that number, 4.455 million, happens to be almost exactly what was paid to build and deploy this model across Oklahoma. And so by the CMMI program. So our conclusions, or mine at least, as always, workflow is king. Community health workers are an incredible asset for this work. They were able to get really high engagement rates. They expanded beyond the family to the household and even beyond that as well. Health-related social needs from where I sit are more like a vital sign than a diagnosis. And those evolve over time. So it's important to screen and rescreen every chance you get to follow that trajectory. And that lessens the dependency on so-called closing loops, which is, in our experience, a very expensive thing to do. Takes a lot of phone calls. If you're just screening again, then that gets you a better outcome metric. Patients can make good choices. Give them options and they will choose. Give them agency and they will rescreen. And we did see that where patients would save the screener that they were sent while they were in the waiting room, and they would use it a week later when their car broke down and rescreen themselves and get a new set of services delivered with no additional effort involved. And visits are not actually required, as I was just saying. They can be screened and get themselves into service anytime. And to me, this was a really good example of doing well by doing good. It was a win for the patient, a win for the provider, and a win for the payers. And I'll leave you with one final question. So why the gap? Maybe that'll lead us into questions. All of our models ended in 2024. It's 2026. We now know this was a good thing, but a lot of it has withered on the vine due to lack of funding and support. So I'll turn it back to you, Laura.
Thank you so much. Wonderful presentations, so much rich data. I'm actually going to just double click on David's last point, which is we just heard from 3 sites where the program has actually continued, which is terrific and totally fits with the incredible savings that we saw from the model. But many sites have not continued. And when the money from CMS ended, those sites closed down. So for instance, there were 3 sites in Texas, and all 3 sites have stopped providing health-related social needs services that were consistent with what they had done under their model. And there actually was a report that came out of Texas not long ago where they highlighted several critical model sustainability factors that they just didn't have in place there and that they hadn't been thinking about or been able to support during the time that the model was functional. And I'm just wondering what it is, what the factors are that each of you has seen in your own sites that you think were the most critical for sustainability in your sites. I think you've all touched on it a little bit, but I just want to put them all in one place together. So if you guys could each talk a little bit about what you think has made the model sustainable in your sites, I think that would be really helpful. And for those of you who are interested in learning more about this, Marisol has provided some great answers about the regional health hubs in the answered questions in the Q&A, because I think a lot of people were asking about this point. Who wants to start?
I'm off mute. I guess I'll go.
Thank you.
So we made the determination, as I mentioned early on, that we would expose the entire community to the screening and interventions. Obviously, we couldn't use the navigation service for our uninsured and our commercially insured during the model, so we did not. But we were able to screen and refer, give everybody access to services, and that thinking continued. And at My Health, we just continued to fund it. One, we were able to land on a very cost-efficient model, right? No doctors, hospitals, or clinics actually work for My Health, so our burden of workflow optimization was really high to get people to do it. And once we had done that, we were able to continue it at a fairly low cost to maintain the infrastructure. But once we continued beyond the model frame, we also began to engage with health plans who were very interested in the numbers that we had delivered, and we were able to get the model deployed to health plans who could subscribe to the service as well for their populations. So we pivoted away from just being point of care to being sort of a regular service of a health plan delivery as well. And that helped to sustain it.
I can
for
speak
help.
from the Camden side. I mean, we are pretty deliberate over what grants we do and don't apply for. And every, CMMI opportunity that comes out, there's conversations about is this the right thing? And I can certainly recall, I mean, it's been almost a decade, but lots of conversations around, are we going to pursue the kind of health communities? I mean, at one hand, we were rallying against telephonic case management. We were saying we need, in-person community-based care management. But on the other hand, we saw this as a huge opportunity to do large scale screening, navigation supports, all the convening work. And so at the end of the day, that kind of opportunity won out and it kind of certainly piggybacked on our existing kind of regional priorities. And, that this question of like, how do we build infrastructure around collaboration was something that we were growing regardless of the accountable health communities. So the idea that and the field of healthcare is moving towards you need more centralized entities that can bring competing and or disconnected entities together. We should be moving towards that separately. And if you don't have that, then yeah, it's harder to sustain something like AHC outside the context of a specific funding opportunity.
Yeah, I can add on to that. I think similarly, Patrick Gordon, the CEO of Recommend Health Plans, was really committed to this vision. And so this was just one step in many efforts to try to address whole person health. I think the other two things that were really helpful in Colorado, one is the policy environment. So Colorado's hospital transformation program, which is it's sort of like a DSRIP program here in Colorado, um, included social needs screening. So hospitals had to do social needs screening. So all of a sudden, the hospitals were very motivated to have plan support and plan engagement around that screening. That's one thing. I think the other thing is because we used existing staff and we had so many clinics and so many staff members screening, people went from sort of intellectually knowing that social needs were important for health and impacted to their healthcare to feeling very passionate about it. And so we had clinics who were very passionate about continuing and were very passionate about continuing to engage Rocky Mountain Health Plans about the future of the model because they either found out their staff had social needs and they weren't aware of them. They'd been surprised by patients. And so I think that culture change piece is more important. I cannot overstate how important that is.
Really helpful responses, everybody. I'm really delighted that Linda Highfield from Texas, the Houston site in Texas, actually threw in a fantastic summary of that report that I was alluding to, where they talk. She mentions really specifically in that report and in her question here or her comment here about like the things that were really hard to do for sustainability, including just like maintaining a bridge organization and multiple alternative payment models at the same time was just really complex. And I guess I just want to highlight that for people who are interested in the sustainability issues, because I think it's really important. And I'm just wondering if anybody wants to comment on this misaligned incentives point that she is elevating, because it's one thing to like have a culture, for instance, Catherine, of like, oh, everybody now believes in it, but then if the payments or the incentives aren't there, what do you do? So was there some way that Rocky Mountain was continuing the incentives or that Colorado was continuing the incentives, for instance, in your site?
Well, I think plans, like just sort of by the definition of a plan, have an incentive in managing costs. And so I think there's an inherent alignment there. It's interesting, Linda, reading your remarks, because one of the things we found that was really interesting is we had a number of different community leads, the like contracted community partners. And the community partners that struggled the most were actually our public health partners. And I think it was because they were so torn between their mission, the politics in their community, the dynamics between the public health system and the healthcare system. And so I do think there is something about thinking about what entity is leading this work and what incentives they already have. A health plan already wants to reduce healthcare costs and has some requirements around whole person care. And so it's sort of a natural alignment there.
David, you want to talk on that
Yeah,
point?
I might just add, I mean, as a clinician, I'm always impressed with uh, the clarity that a value-based payment model or a risk-based model brings to a provider group. We did Comprehensive Primary Care Initiative all the way back in 2012, 2016, and that motivated the providers to need outside data and to be interested in what was going on outside. And similarly, I think they start to think more like health plans and prioritize things like social needs in their clinical settings if they realize what that does for reducing costs, part of which they will partake in.
I think one of the points that Linda made to me in a one-on-one conversation at Academy Health just recently, I happened to run into her, and she pointed out that the the misaligned incentive was, and Linda, forgive me if I get this wrong. I'm sorry, I can't personally unmute you, but we can figure that out for a future conversation. Um, was that the in Texas, like at the Houston site, the hospital actually wanted people to be coming in. They wanted the expense was actually a moneymaker for them, whereas for the plan, they want to keep people out of the health system. So like that's part of the misaligned incentive for there. So like that their health system was not thinking like a plan in that particular case because they could make money, and that's why they've shifted towards the uninsured as opposed to the insured population because they lose money on the uninsured population, but they make money on the insured population. So that's the misalignment, which I think is really important to think through if we want to continue this health-related social needs work. There are a couple other questions. I think we have time for one. There are many answered questions, and again, the recording will be available to everybody, including the Q&A after the talk. But just I think there's a really interesting question that relates to Erin's comment about switching to telephonic services. And somebody points out that like there has been some work showing that filling something out on digitally may lead to more honest answers than doing things in person with somebody. I think there's some related question of like the relationship building that you can do in person versus telephonically. Like, I was just wondering if you guys want to take the last couple of minutes to just talk about those kinds of differences. Like it also happened during COVID, overlapped with COVID. So like everybody switched to phone because we were able to. Are we going to switch back? Like, so anybody who wants to comment about those kinds of questions, I think it would be really helpful for people who are trying to start this work in their own sites.
I can sort of answer some of that. I was able to answer the question and the question answer, but I think it really depends on your site. It depends on the population that you're working with, the community you're working with. It was really good for us to have both to be able to do that. There were some people, yes, that were comfortable. We had them in tablets. They did it in tablets and answer those questions. But there were a few that, really sort of needed that one-on-one and you don't have to be there to sort of know that. I'm a true believer in sort of body language and picking up cues that are not said, right? So you could tell when someone is uncomfortable, you could tell when they're uncomfortable with you. So giving them the opportunity to have something to do with digital worked very well, but you had to have those two at play. You couldn't just offer one and not the other as well.
Thanks, Marisol.
Like the Camden team, we had all the methodologies. We had calls, we had paper, we had a tablet option. And I would actually encourage having as many different avenues as possible. Our team had a lot of anxiety about duplicative screeners, and the data just really didn't bear it out. The majority of people were screened once in the full time period, over multiple years. There was a very small subset of people that were screened 10 plus times. It was, 1% of the population. And so I think as much as possible, trying to outreach people about their social needs for us just seemed like the far better approach than being concerned about duplication or too many different methodologies. But I'm really impressed by David's results. So I want to hear more about David's thoughts.
Well, and I should hasten to add, I mean, when we began, we were going to have 0 clinical organizations participating because there was just no time to add the screening. And on top of that, in any given clinical site, and I happen to work in a free clinic where we make every effort to screen everybody, even in person for social needs. We have to make choices. We don't have enough warm bodies to do screening for everybody. And when you have to make those choices, then bias comes into the mix. And, the woman arriving in the mink coat is not going to get asked about social needs compared to, the guy in torn clothing. And so we, from where I sit, our goal was to create the floor that everybody would get the same treatment and the same degree of screening. And then we fed back those results. I didn't mention that in the process, but part of the process was to feed back the screening results to the clinical sites so that then they could triage and take the next level, what I'll call secondary screening. and have that in person. I will also observe that we had a fairly high, maybe higher than expected, detected rate of interpersonal violence. And I do feel like there's a certain, especially in this rising generation, I've got kids, many of us do, they'd rather commune with their phone than another human and trust it more. And I think some of the literature is showing that. So totally agree that the ideal is to have a human-to-human connection for this conversation. But failing that, we felt like we needed to create a floor that was sane and universally available to everybody.
Super helpful. I'm appalled that the time is gone. It has evaporated before our very eyes. And it's so sad because there are a zillion more questions that I feel like I have, and I'm sure the audience has. I want to encourage listeners to reach out to these amazing experts about accountable health communities and other work that they're doing around health-related social needs. Again, we'll make this available to everyone. I'm so grateful to the four of you for making yourselves available. Mighty Soul, congratulations to you and your family today. I hope all goes well. And thanks everybody for being with us today. We look forward to future events. Really appreciate you.
It was great being here. Thank you.